Differential diagnosis of acute scrotum. The term acute scrotum refers to the sudden onset of scrotal pain, swelling, and/or erythema, often accompanied by systemic symptoms such as fever. This condition requires prompt evaluation to identify and treat potentially life-threatening or fertility-compromising conditions. Key differential diagnoses include 1. Testicular torsion, pathophysiology, twisting of the spermatic cord leading to ischemia and potential testicular necrosis. Clinical features: sudden, severe unilateral scrotal pain, high riding testicle with horizontal lie, absent cremasteric reflex, nausea and vomiting, urgency, surgical emergency. HARP 2. Epididymo-orchitis, pathophysiology, infection, inflammation of the epididymis and/or testis, usually caused by bacterial pathogens, e.g., E. coli, Chlamydia trachomatis, Neisseria gonorrhea. Clinical features: gradual onset of scrotal pain and swelling, fever, dysuria, or urethral discharge, positive preen sign, pain relief with elevation of the scrotum, urgency, requires antibiotics but not emergent surgery. HAPR 3, torsion of testicular appendages, pathophysiology, ischemia of a testicular appendage, e.g., appendix testis or appendix epididymis. Clinical features: gradual pain localized to the superior pole of the testis, blue dot sign visible under the scrotal skin. Urgency, usually self-limited, symptomatic management. 4. Inguinal hernia with strangulation. Pathophysiology, protrusion of abdominal contents into the scrotum, potentially leading to vascular compromise. Clinical features: painful, irreducible scrotal swelling, gastrointestinal symptoms, e.g., vomiting, abdominal distension. Urgency, surgical emergency. 5. Trauma, pathophysiology, direct injury to the scrotum causing hematoma or testicular rupture. Clinical features: history of blunt or penetrating trauma, severe pain and bruising. Urgency, may require surgical exploration. 6. Idiopathic scrotal edema, pathophysiology, benign, self-limited inflammation of scrotal tissue. Clinical features: painless or mildly tender scrotal swelling, erythematous skin with normal underlying structures on imaging. Urgency, conservative management. R7, Fournier's gangrene, pathophysiology, necrotizing fasciitis of the perineum, scrotum, and abdominal wall. Clinical features: severe scrotal pain with systemic toxicity, fever, hypotension, crepitus, and foul-smelling discharge. Urgency, surgical debridement and antibiotics. Investigations for acute scrotum. 1. History and physical examination. Detailed history of symptom onset, progression, trauma, or systemic symptoms. Examination for testicular position, tenderness, swelling, erythema, cremasteric reflex, and inguinal region. 2. Laboratory tests. Urinalysis. Detects infection, pyuria, bacteriuria. Urethral swab or NAT. Tests for sexually transmitted infections like chlamydia or gonorrhea. Complete blood count CBC. Elevated white blood cells suggest infection or inflammation. Blood cultures for systemic signs of infection. 3. Imaging studies. Doppler ultrasonography, diagnostic tool of choice. Testicular torsion, reduced or absent blood flow. Epididymo-orchitis, increased blood flow, hyperemia. Hematoma trauma, disrupted parenchymal architecture. X-ray or CT, useful for suspected inguinal hernia or trauma. MRI scrotum, rarely needed, used for equivocal cases. 4. Exploratory surgery, indicated if testicular torsion is suspected but not confirmed by imaging. Management of acute scrotum. 1. Testicular torsion. Immediate management, emergent scrotal exploration and detorsion. Orchidopexy of both testes to prevent recurrence. Prognosis, salvage rate decreases significantly after 6 hours of ischemia. 2. Epididymo-orchitis. Antibiotics, if less than 35 years or STI suspected, ceftriaxone plus doxycycline. If 35 years or UTI suspected, fluoroquinolones, e.g. levofloxacin. Supportive care, analgesics and scrotal elevation. Follow-up, resolution of symptoms, repeat imaging if no improvement. 3. Torsion of testicular appendages, supportive care, analgesics and anti-inflammatory agents. Warm compresses. Follow-up, spontaneous resolution in 1 to 2 weeks. 4. Inguinal hernia with strangulation. Emergency management, urgent surgical repair, bowel resection if necrosis is present. 5. Trauma, conservative management, minor injuries, rest, ice packs, analgesics. Surgical management, testicular rupture or large hematoma, surgical repair. 6. Idiopathic scrotal edema, supportive care, rest, analgesics, and reassurance. Follow-up, resolution within days. 7. Fournier's gangrene, emergency management, broad-spectrum antibiotics, e.g. carbapenems, clindamycin, aggressive surgical debridement. Prognosis, high mortality, early intervention critical. Summary, table, diagnosis, investigation, finding, management, testicular torsion, absent blood flow on Doppler, emergency surgery, epididymo-orchitis, hyperemia on Doppler, positive antibiotics, torsion of appendages, blue dot sign, localized pain, supportive care, strangulated hernia, bowel gas in scrotum, imaging surgical repair, trauma, hematoma or rupture, Doppler CT, rest or surgical repair, Fournier's gangrene, necrotic tissue, systemic signs, surgery plus antibiotics, prompt recognition and intervention are essential for preserving function and preventing complications in cases of acute scrotum.